Hello, everyone. Happy Monday. So it's April 21st, 2025, and you may be looking at the screen thinking, Domain 4, we just completed domain number 1, and you are absolutely correct. But I actually decided to skip domains 2 and 3 and come back to them at a later date for a couple of reasons. Number one, I feel like there's a connection between domain 1 and domain number 4. Also, domain 2 and 3 are closely tied together. So I really wanted to do some what do you call it? I wanted to add some additional content in the review of domain 2 and 3. So, domain number 4 is, I would say it's a pretty large domain. It's 20% of the exam, but there is so much of a connection from here to domain number 1. I felt that it was important for us to cover them back to back. So domain number 4 is tied for second place with domain number 2 from a percentage perspective. There are 6 tasks that you are expected to be able to perform for this domain. And as I was thinking about this domain, it occurred to me that many of you are either already coding, but you may not be as involved with the, what do you call it? The reimbursement, regulatory side. So I wanted to bring some things in, talk about some things to help make it clearer for you as we go through this domain. So the first thing that we're going to do today, there is a 35-minute video that I want to show right now. And just to give you some perspective on the video, it is a revenue cycle meeting taking place at a hospital with different stakeholders from different departments. So I would encourage you to take notes, which leads me to something else. I don't know if you guys take notes every Monday and Wednesday, but I would highly recommend that you do, because taking notes is how you have information to take with you after this review is over. So let's get into the video right now.
Good afternoon. Welcome to today's DNFV meeting for Parkview Health. My name is Carla Pettigrew Dangerfield, and I am the Health Information Management Director for Parkview Health. I wanted to take a few minutes to explain what is the importance of the revenue cycle management in healthcare. So revenue cycle management can be defined as the process of handling claims, processing payments, and generating revenue in the healthcare organization. It begins just at the time when a patient makes an appointment or is hospitalized, and it continues until the balance on the patient's account becomes zero. It includes various steps like checking the patient's insurance eligibility, coding claims, getting physician documentation completed timely, and then billing out the balance due to the insurance company and the patient. Revenue cycle management is also responsible for all of the administrative tasks to include informing patients of an upcoming appointment, scheduling patients, reminding payers and patients of an existing balance, and questioning insurers when a claim is denied. Communicating with health insurance companies is a very important aspect of revenue cycle management. When a patient schedules an appointment, the healthcare organization typically checks the patient described insurance coverage to see what method of payment will be used to follow up with billing and collecting the patient's account for services rendered. Revenue cycle management is a crucial function of the hospital and physician practice revenue streams. Poor management of the revenue cycle process can make or break a hospital or a physician practice. Revenue cycle management should be managed very carefully and very wisely. So at this time, we're going to take a brief introduction of each member of our DNFB meeting, and I'll start to the left of me with Tana.
I'm Tana Vandy-Putty, and I'm with Revenue Integrity, and our goal is the achievement of compliance and operational efficiency within the clinical departments and reimbursement. And besides Revenue Integrity, I represent the clinical departments here, since we're more of a clinical liaison.
Okay, I am Sandy Oswald. I'm the Patient Accounting Billing Manager for the hospital claims. As my contribution to this meeting, I review many different items in our dashboard for my area, and I also watch a few of the clinical areas along with Tana. I keep an eye on the rehab claims, continuing care claims, research, and a few x-ray departments and labs. Along with my own areas, I keep an eye on the DNBs and the claim edits for our billing. Make sure we stay within our goals, get everything out timely, and the dollars collected timely.
Good afternoon. My name is Jill Shirley. I'm Director of Coding for Parkview Health. And the piece that we have, of course, is the coding of the accounts so that the bill can go out the door. Our goal is to be, and we'll discuss this a little bit farther into the meeting, is to be at 3 days out from candidate for bill. And so as we go through the dashboards and some of our explanations, we can explain where we are towards meeting that goal.
And I'm Ursula Edie, the coding manager for Parkview Health System. And as Joe mentioned, we provide the coding services for all of the services rendered. And we also work with the providers to ensure that the documentation supports the services billed. One of the things we do is monitor the top accounts from a financial standpoint, and we also look at the oldest dates of service to ensure that we receive a reimbursement for services rendered.
I'm Tina Walborn. I'm the Director of Patient Access. Patient Access encompasses registration across the entire health system. So the revenue cycle starts either with the scheduling of an appointment through our teams in imaging diagnostics, or through registration when the patient presents for ER visit, admission, or outpatient. So it's critical that our teams identify the patient appropriately and start that process in our electronic medical records system, including identifying the proper insurance coverage and along with who is responsible for the bill to start that process. In addition to registration, our division includes financial counseling, who also is very important to securing payment stream for the organization in the revenue cycle, including working very high dollar accounts daily for our tertiary medical center for third-party liability accidents. So my role is oversight of those queues to make sure that we are always at goal, and our goal is to be below the threshold of the top end of the green. So every day we look at that, our leaders look at that, and they're accountable and assigned to our DNB and claim edits.
And I'm Ginger Lutman. I'm the Patient Access Manager for Parkview Noble and Parkview LaGrange. And my role in this is to monitor DNB and claim edits for my 2 sites.
I'm Erica Phillips. I'm a supervisor over the financial counselors in Patient Access. And my role with the financial counselors is to work on third-party liabilities, in which dates of service the patient may not have health insurance, or there's other insurance over the primary insurance, such as auto insurance or personal injury situations. So we could be reimbursed for other insurances such as homeowners insurance or auto insurance. Health insurance could deny a claim if they feel that someone else should be paying primary. So during the DMB, my area for focus is high dollar accounts and also difficult resolution accounts.
And I'm Lindsay Daniel. I'm the Patient Access Manager for Parkview Regional Medical Center. My role in this meeting is to work and also monitor the DNB and claim edits for my sites as well.
And I'm Joni Hissong, Director of Case Management. And one of the groups that report to me is the Utilization Review Nurses, and they compile and send clinical to the payers to make sure that our days are covered while the patient is here in a bed. So my role is to make sure that we're getting those authorizations obtained timely, sending the clinical, and then it's accurate and timely and tells the whole story of care so that we can be reimbursed as required.
So we want to define what DNFB is and what the purpose of this weekly meeting is. So the acronym for DNFB stands for Discharge Not Final Billed. DNFBs are accounts that have not yet been billed at the time of discharge. The accounts are then listed on the DNFB list, which will be reviewed during this meeting. The listing of DNFBs will include patient accounts categorized as discharged but not billed. Accounts may be unbilled for a variety of reasons, such as the following. Physician documentation is incomplete. The accounts need to be coded. There is a missing order or an invalid order, or there are billing errors. These are just examples of a few of the things that we look at. The next thing we want to do is take a look at our AR days and the CFB. AR days are the total number of days that accounts receivable has still not been billed. Candidate for bill are claims that are past the mid-date hold 3 days post-discharge and are ready to bill once all of the edits are resolved. The goals for Parkview's AR is to be less than 5 days of accounts receivable unbilled, and for candidate for bill to be less than 3 days. So now we're going to take a look at our out-the-door tool that we use in the revenue cycle to see where departments are with the totals of AR in their buckets, and to discuss what some of the barriers might be as to why they may still be in the red status, which means that we're not hitting goal, and those in the green status means we are hitting goal. So we'll first start off with coding.
So coding,
There we go.
yes. So coding started January 2017 at about 11 days. We had a very large backlog due to multiple things happening, staff, loss of staff, as well as the push through the year end. We had a little bit of a common cause blip in January. We currently are at 5.8 days, and as we said, our goal is to be 3. So you can see when you look at the screen from the run date, which was today, even from yesterday, there's been a significant drop. And so each day we've experienced a drop. We begin each week lower than we began the week before, so we are well on our way to reaching our goal. As well, we have other goals in terms of when the month is closed. We like to close the month. So January, we should close January by February 8th. And right now, because we're off that mark, because we are not at 3 days, we're at 5.8, we have a goal of closing the previous month by the 15th of the next month, and we're gradually ratcheting that down to the 14th and the 13th and the 12th, and so we are on our way to reaching our goal. We hope to be right-sided by July 1, and we are currently ahead of that goal. We don't know, we don't want to say that we're way far ahead of that, but we are ahead of our goal to be right-sided at 3 days by July. So we're happy with our progress, although it's not where it is. One of the things that happens is when coding is not processing the bills as quickly as they normally do, then that changes the results for Sandy, my partner to my right. And that changes her colors as well. So I will reach green. Sandy will still be somewhat red, because as we're pushing them through, that causes a bolus for her to work and her team as well. So you can kind of see this over the long term as different groups they're red and they start to approach their yellow and their green. Their impact on other groups causes them to maybe even go from yellow or green to red or continue in red for a period of time. So we are working our plan, and so far for us, the plan is working well.
Okay, for billing, our D&Bs for billing have come down since Monday. Our billing staff is currently on overtime. We did go up a little bit yet since yesterday, And as Joe said, as the teams ahead of us complete their work, it's going to trickle on down. And I know everybody's been focusing on their high dollars. So as they get rid of their high dollars, my high dollars will grow. But we have come down quite a bit since Monday. In my D&Bs, I will see multiple different edits we see. One of the items we've seen this week is our infusion series have dropped, and these are multiple visits that can be high dollars due to drugs. And a series visit is going to be a visit where a patient returns multiple times in the same month for the same type of treatment and service. All that month's services will go on one statement. So they could be rather large when they do drop. And we do have multiple different types of series. We can have our infusion series, we can have occupational and speech or physical therapies, we can have cardiac rehab, there's series for the cancer treatments, and all these different series are set for a different series to drop about every 7 days. So our series that dropped recently this week was a high dollar series, and that kind of boosted our totals a little bit this week. Some other things that we watch in that area is for overlaps, and we will catch a lot of overlaps where payers will have different rules, and it's billing edits and claim edits that are also watched, or I'm sorry, billing edits that are mostly in here. So that is why our D&Bs are up a little bit this week, but we do have billers on overtime, and they are working as fast as they can this week.
Okay. Revenue integrity, ours is red, and our group captures all of the observation accounts. Our nursing staff of like 10 nurses review all of those and manually add the charges due to all carve-outs and such that are required. I think that's the biggest increase in our area right now, are the observation. And then with our clinical departments, this captures all of our surgical logs. All surgical cases generate a log that has not been posted, which is waiting on the clinical documentation. Once that's complete, then they can post the log, and then that removes the surgical log DMB. And that actually looks really good because that's down. And then our charge review. This is the area for all clinical departments. They have a high dollar, high quantity, and dates out of range, along with a few $0 charges where we don't have procedures created. That's research. They look at it back there on the router. I think that's about it, which that looks really good because that's green.
I do see the sniff area is red, and I have talked to the sniff area. They have very few accounts there, but they are all a week or less old, and they do have 2 high dollar accounts in there, and that's what raised it. They do have 7 days before Medicare returns what they need to get the claims out of there, and all of their claims are 7 days or less right now at this point.
So for registration for discharge not billed edits, we are below goal. The types of things that would hit in our edits for discharge not bill are examples for an account that may be coded as an accident-related diagnosis, and the system is smart enough to know that there should be accident information loaded on a claim form within the registration, so it looks for that edit. Another common edit that we see is the coverage for the insurance doesn't have the corresponding date to the date of service. So those could be valid errors where we may not have put the appropriate dates in upon loading the coverage, or it could be a situation where there was a change midway through the stay, and then we would evaluate that and partner with our cohorts over in patient accounting on how to process that. These edits are managed and worked by the leaders, as I mentioned earlier, so every day we all look at this dashboard to see if we're at goal, and they're also prioritizing their queues And if someone's on vacation, then they make sure that they have a backup, and we all work in it as a team to watchdog that to keep it goal, because we need to make sure that we're not holding up the front end process so that the claim can continue to move through the process and get billed.
So claim minutes look really good. Everybody's in green this week, except for rehab. Do you know anything about rehab?
Yes, I did talk to rehab. They have 5 accounts out there, and they are actually getting 3 out of there today, and they plan on the other 2 to be resolved tomorrow. So those should be taken care of yet this week.
Okay, we're going to move on to the review of our top 10 accounts. And every week we look at our top 10 accounts, our top 10 in each area that are of the highest dollar, and see if we can get them billed off as quickly as we can to drop our AR. So we're going to look at the first area.
Patient accounting.
Okay. In my review, I found our most common things were in regards to review of a discharge code for home health. And we always stop these claims and check them. If the patient would continue on to home health, we will receive a transfer payment. But if the patient does not follow through or changes their mind and does not continue with home health, we need to change a code on our claim and we will receive our full payment. So this does make a reimbursement difference. So we do double check those. Another thing is our Part B splits. When a Medicare claim does not meet full medical necessity, we may have to pull the diagnostic charges for like lab and x-ray or EKGs off to a separate bill and have these recoded, and everything needs to be put on a separate claim, and it takes a little bit to work. So we handle those differently. And then we run into our overlaps. Sometimes they're called consecutive overlaps. We could happen to have 2 outpatient visits in the same day that may need combined, or we may have an outpatient before an inpatient, and then if they're related, then we'll have to go further and combine them. Or we could have 2 inpatients that are just within a certain time frame. The time frame could be up to 30 days. And then we have to have codings help to review those and see if they are related. And then these would all be combined, or we would put extra codes on the claims and send those in to get our full reimbursement. So most of these were, everybody was working and had them in review, work queues to be reviewed, or they were ready to resolve. But those were our high dollars for this week.
What's that for mean?
It overlapped 4 accounts. We had 4 accounts. And that's a problem with some of the series and the multiple series types we have. They had 2 different series types going along with 2 outpatient visits during their 2 series. So it's got to carefully see when they're related and what days are on which series and what can be bundled or left on a separate claim.
So with the financial counseling working the third-party liabilities, some of the reasons that we look at accounts for difficult resolution are the patients may not be cooperating to give us the information. We also utilize a website to get police reports so we can obtain insurance information for car accidents that way. Also, the patient may have obtained an attorney. So sometimes, attorneys are difficult to reach, so that may take some time as well. And then also the police reports that are being updated on a website that we utilize, just making sure they're updated timely so we can get the information. So in my area, we also work what you call a lien, basically to secure payment for these third-party liabilities, which have to be filed within 90 days. So we work closely with our paralegal who submits the lien for which the county in which the hospital resides in. So the top 5 that I have, basically I took them from the highest balance. And the first one is a 2 motor vehicle accident. The patient was severely hurt, so he was unable to speak with us, and there was no family available. But we did obtain the police report, and so we're working diligently from that. I also monitor when the last time the financial counselor looked at the account and placed a memo, and how many days it's been in the work queue. The second account, actually the second and the third account, they were passengers. They were in the same vehicle together. So pretty much they're mirroring each other. They were actually discharged before the financial counselor could see them. So sometimes that takes a little bit longer for us to get the information that we need once a patient is discharged. So it's important that we make the visit while the patients are there. And then we have a patient who actually fell at a grocery store. So some of these situations are unique. I personally spoke with the patient, and they said they obtained an attorney. So I'm following up with the attorney. I also placed a phone call to the grocery store to get the information to see if we can get claimed for billing. And then the last example that we have is workers' comp. And typically our insurance verification team works the workers' comp cases. We watch them though, just to see they may be related to some type of lien situation if it's not workers' comp.
Inpatient and outpatient coding. You'll see up here several examples of reasons that an account may hold, and what we do is we look at the top $10 accounts both on the inpatient and the outpatient side for hospital billing. And you'll see that some of these are holding for clarifications that are out to clinicians. That is a process in the inpatient DRG coding. If there's additional documentation or they need something linked by the clinician, diagnoses linked together, you'll see clarifications or queries out there for clinicians. As in the first one, you'll see that this case was coded on 221, and then it was undone because we needed to do some billing and rebilling within that. And so then we recompleted that account, and hopefully now it will go out without hitting additional edits. But this is one of those examples that Sandy was talking about where we have to partner together and cases may move between us. And so we have to be very vigilant that we're each doing our pieces timely so that we can get it passed back to the other team, so that we don't end up in a situation where it is too late to bill the case. We have taken too much time to bill the case. You will also sometimes see, because we work these accounts consistently and constantly, that a case, by the time we come to the meeting, has already been sent to be coded yet today. So those cases then will be on their way to Sandy as long as they don't hit an edit as well. Then you'll also see a notification where it says DS for a particular clinician. This is a case that is missing particular documentation that we cannot code without that documentation. And so this is where we work with Carla's team in terms of making sure that the deficiency is placed for the clinician. And it is up to Carla's team then to watch that clock in terms of time against Joint Commission standards of when documentation needs to be completed. So we have communication back and forth, and then when it's gained, the documentation is gained, then Carla's team sends it back to us into a high priority queue so that we can code that. And so that is on the inpatient side. On the outpatient side, you'll see much the same. Reports that are needed for clinicians, edits that need to be cleared, something might have been sent to be coded. You'll also see that we oftentimes run into an inpatient-only procedure that has been performed on an outpatient basis. And in that situation, then we have to work with Sandy's team and everybody else to make sure that we get this reclassified into the right patient status, and then the case is reworked and rebilled and moved on through the system. So you'll see that a lot of these cases move back and forth between us before they finally go out the door and a patient bill is generated.
We have observation accounts that are held up, and those are pending the nurse, which those should be reviewed yet today. Then our pending auth, that means that we're waiting for Joni's team to decide whether or not it's inpatient or observation, so then we'll know how to review the chart and review for observation charges, or we can just let it go on through and bill as inpatient. Then we have the less than 2 midnight rule for Medicare, and we have to send that to Joni's team to find out if it's medically necessary on the inpatient portion. So we're pending a response from them right now. Pending auth. An observation with a Cupid log, meaning that the patient was in the cath lab. So we've got, after we do our observation piece for charges, then they could probably release it whenever their documentation gets done to release the charges there. And then the surgical logs, and that's it, but nothing out of the norm.
Okay, the next segment of our meeting requires us to go into our EPIC electronic medical record, and within that system we have a single billing office dashboard, and we're able to take a look at accounts that are stuck that we need to have some work on. So we're going to review, the first thing is our DNFBs that are not on a work queue. So that'll be the first thing we'll take a look at. So coding has 2 accounts that are in that work queue, and so we'll have them take a look at those accounts.
And then the clinical account I did look at earlier today, and it was just the clinical department that didn't complete the OCE referral process correctly. So then I referred that back for them to follow up on.
But otherwise that looks really good, much better.
For 3 accounts, yeah.
The next area that we take a look at is accounts should be discharged.
That area I'm responsible for on the leader side, and this work queue catches any account that's not discharged. We work the outpatient with ambulatory accounts. So if a patient comes in for an outpatient surgical procedure, that's where these fall if they don't happen to get discharged. So we go in here and then we actually find the date and the time that the patient was discharged, and then we actually perform that so that we can move it along to the next billing cycle.
And the accounts that are sitting, like that one, the 322, does that just need Tina's magic?
Nope, the Tina Magic was already done. It will fall off today. Yeah.
Oh, that's right. Because it says D&B.
Yes.
Yeah, okay.
So
what about the
So the
other?
Inpatient ones, yes, the magic needs to happen, which will be done today. So that way it'll push through
So then that's
tonight.
259,000.
Yeah, so this will this refreshes every day. Yep.
The next area that we're going to review is timely filing. So on this particular area we have 46 accounts for coding to take a look at. And timely filing means that we're running out of time to send our account to be billed. We have 30, 60, 90 days by payer. Every payer contract has a certain days for their filing. So these accounts have fallen in here to alert us that we're running out of time to get them billed. So we're going to take a look at these and have coding follow up with the 46 accounts and see what can be done to move them through the billing process.
I see 14 of them were billing, and I know the supervisors were working those this morning. I had sat with them, and they're working through those. I have 2 new supervisors, so we sit down and do them together.
And the clinical one I did follow up on, and that was just referred to the therapy rehab department this week. So it was probably, I'm guessing, a split or something.
Oh.
A Medicare split account.
Split bill.
And so it's an old account, so it looks like it's hitting the timely filing, but it just got referred to them.
Yeah, and a lot of our split bills do hit the timely filing, but when Medicare comes to those splits, they are, sometimes it will take a few months to determine, and if we're appealing a decision, these accounts may be 6-7 months old, and this work queue may be for up to 90 days, but some of our payers do have a 1-year file limit. And our splits may be appeals, which would even extend our file limits. So not everything is going to fall out of file limits, but it's a way to keep track of things we need to work quickly.
And so the 46 that are on the coding dashboard, these are cases that we're continually working through as well to make sure that there is something that is billable within that case, and or is it combined with another case? Does it need to be split apart? Is it something that has gone out and has now come back, and we need to work on that? Are we working with another team on them? So this is something that we work this area. Lisa works this area continuously and daily, and so you'll see that number move back and forth from varying amounts determined by what is in that queue at that time.
And then the no owning area, that's something new with Epic since we're still
Right.
working through little things. And we have a meeting at the end of this month to determine owning areas.
Yeah.
So the last part of our meeting, we open it up to discuss any other problems, accounts, anything that we need to discuss that may be holding up the DNFB. So I'll open it up for any discussion.
I don't have anything.
I don't have anything new to bring up.
Nothing new here.
I don't have anything.
Not either. Me neither. Looks good in the counseling world.
I don't have anything either.
Okay. So this concludes our DNFB meeting. Thank you.
All right. So hopefully there were terms in this meeting that you recall from last week. One of the things she talked about was the outpatient code editor. But they kept on mentioning claims. They kept saying claims, 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 claims. So I want to start to talk about the claim form that is used in the inpatient setting. I'll talk a little bit about it, and then we'll take a break, and then I'll continue. So AHIMA does not specifically call out claims on the content outline, but one can infer that it is definitely something that you need to know because you're coding for the hospital. Ultimately, the work that you're doing is going to go on a claim. So the claim form that I'm going to talk about tonight is called the UB04 claim form. And it is the insurance claim form, or I guess you could say in the electronic world, it's the flat file that is used to bill institutional services, such as the work that is performed in the hospitals. So on the form, on the paper copy that you're seeing right now, it contains data entry blocks that are called form locators. And this claim form is for Medicare Part A. And something that I just thought about that I want to call out for the CCS exam, and we're going to talk about more about domain 5 or domain 4 tonight. But on the CCS exam, you need to know about the different payers. And so the largest payer of healthcare in the United States is Medicare, and Medicare is divided into 4 parts. So Part A is for hospital work, skilled nursing facility, home health, hospice, dialysis, rehab, as well as I believe that rural health clinics use this form as well. So as you can imagine, you're not sitting, we're not sitting up typing out the information into the claim form, right? It is input into a system. And I don't know if I mentioned this, but I'm going to say this. On this claim form, there are 81 blocks, and the blocks are called form locators. And after the break, I'm going to talk about the 81 blocks. So claims are usually generated when the charge master, and hopefully you all know what a charge master is. And if you don't, that is another item to put on your list of things to research before the exam. But it's usually when the charge master and other data is collected with the electronic health record and is sent over to the billing department, and then the billing department sucks all, I don't want to say sucks all the information out, but that's pretty much what happens. It goes over to that department. This claim form, you notice it says UB04, but it also says CMS 1450 because that's like the legal name of it. But in the industry, we literally call it the first two letters, the UB. There is this committee called the NUCC or NUBC, National Uniform Billing Committee. And they are responsible for identifying and revising the data elements that go on this form. And so this form is used by all institutions that are going to be billing Medicare. So it gives us that uniformity. So there are 81 blocks or 81 form locator fields. And what happens is, as the patient goes from admission to discharge in some shape, form, or fashion, that information is collected and then placed onto the claim form. Now, for purposes of the CCS exam, I don't envision them actually giving you a claim form and asking you to know what the information is. But just in case they ask you a question, you will hopefully walk away tonight with some information to just better understand the form itself. Also, it is my desire that you will understand the role that we play. So for tonight's presentation, the area that I'll be talking about at a point in time will be, for the most part, the area that is highlighted in blue. So I'm going to start to talk about the form just a tad bit so that we can get into it before we take a little break. So in form locator number 1, this is where the billing provider's name, city, state, zip code, telephone number, fax number, all that stuff goes there. And when we credential with an insurance company, this is the information that they have on file, so they recognize our organization as one that they know. All right, number 2. This is the billing provider's pay to address. I like to say this is where we want the check to go. Now, let's face it, it's 2025. A lot of claims we get paid electronically, but this information is needed in case the check needs to be old school, physically mailed to us. 3A and 3B. So 3A is called the patient control number. And I think organizations have different names for this, but I like to say that this is the number that identifies today's encounter, because as you know, patients have multiple encounters, and if you want to call the insurance company to ask about a particular encounter, you you don't want to give them information for other encounters. You want to be able to have this one. Okay. So that's that number in 3A. 3B, that's the medical record number, right? So that's like the overall medical record number that we can pull up all the visits, but the patient control number, which some places call the encounter number, is where we can locate that particular visit. All right, so it's been about 45 minutes. So let's take a 10-minute break. And I will play music, and that'll let us know when time is up once the music stops. Everybody, so we are back and we are continuing our conversation, introduction to the UBO4 claim form. And so we're going to start with form locator 4, which is the type of bill. Now, you may remember when I did the demonstration for APC grouper that the first question it asked me was, what was the type of bill? And you might not have noticed because I was kind of probably going through it pretty fast. But just to show you the difference, when I showed you the DRG, the system asked me for the discharge status first. All right, so the type of bill is a 4-digit number that provides 3 specific pieces of information after the leading 0. Digit 1 is the 0, which is typically ignored by Medicare. Digit 2 is the type of facility, such as hospital, skilled nursing facility. Digit number 3 classifies the type of care that is provided. So inpatient, outpatient. And then digit number 4 indicates the sequencing of the bill. And you may recall in the, what was it called? The revenue cycle meeting, they talked about situations where they may be having to send out multiple claims. So, like, let's say the patient has physical therapy and they come twice a week for 6 weeks. So part of the claim may be on part of the services may be on one claim, the other part may be on another claim. All right, form locator number 5 is the facility's federal tax ID number. And one of the things that I really want you to walk away with is that some of the information that's on the claim is set up when the system is set up. Some information is captured by patient access, and then some is captured by the coder. Form locator 6. This is where we enter the beginning and ending dates of the period that is included on this particular claim. Number 7 is going to be left blank. 8 is divided into A and B. A is going to be the patient's payer identification number, which is the subscriber number that's going to be entered in form locator 60. We'll see that at some point. And then 8B is going to be the patient's last name, first name, and then if they have a middle initial. 9 is organized in A through E, and I think I mentioned that the form locators that I'm talking about are typically shaded in blue so that you can see them from the rest of the form that's being shown. So A is the street address, B, city, C, state, D is going to be the zip code, whether it's 5 or 9 digits, and then E is the country code if the patient resides outside of the United States. All right, 10 and 11. So 10 is going to be the patient's date of birth, 2 digits for the month, 2 digits for the day, and then 2 digits for the year. 11 is the patient's gender, and the options are male or female. 12 This is where we enter the inpatient date of admission or the home health start of care. And this will be 2 digits for the month, 2 digits for the day, and 2 digits for the year. 13 is the hour that the patient was admitted. And I'm sure that many of you know that the hour is, or that time at a hospital is going to be military time. All right. 14, this is where we enter the type of admission or visit. This is required for inpatient claims. And this item here is actually entered by patient access. And let me just go back for a second. So, type of admission is going to be like emergency, um, newborn trauma center. All right. Oh, I'm going backwards. We don't want to go backwards. We got 81 blocks to get to. All right. 15, point of origin. Here we enter a 1 digit source of admission or visit code. So, physician referral, clinic referral, transfer from a skilled nursing facility, transfer from another organization. 16, the discharge hour. And that, of course, is going to be in military time. 17, the patient discharge status. This is a 2 digit discharge status code. And as I mentioned just a few minutes ago, when I did the demonstration of calculating the MSDRG, one of the first questions that they asked me in 3M after I put in the patient's gender, age, it asked me for the discharge status. So where did the patient go after they left the hospital? All right, form locator 18 to 28. These are called condition codes. And this is a 2 digit code that basically talks about stuff like, is this condition employment related? Is patient covered by insurance that's not reflected on the bill? Keep in mind that sometimes patients come in and they have an auto accident. You saw that in the revenue cycle meeting. They come in and they fail on public property, and so the patient's own private insurance is not going to pay for this bill. All right. Form locator 29. This is the 2 digit state if the patient had an accident. 30 is not used. 31 through 34, these are called occurrence codes. And occurrence is things like accident, no fault insurance, accident, employment related. So you can notice that a couple of these are situational, meaning that if there has to be a certain situation that would apply. All right, 35 and 36. So 37 is actually not used. I don't know why I have it on here, but 35 and 36. Occurrence span is showing, it's an occurrence span code, which is like, I think they're 70 through 75. And then it shows the beginning and ending dates for a specific event. And like I said, 37 is not used. All right, 38 is for the responsible party. And here you're going to put in the responsible party name, address, phone number, all that good stuff. Or not phone number, but address. 39 through 41, these are called value codes. They are 2 characters. So, for example, 50 is for a physical therapy visit. Again, keep in mind that this information gets on here by multiple parties and it may not be us. And I say us as in coders. All right, form locator 42. This is where we enter the revenue code to identify accommodation and or ancillary charges. So when I did the demonstration of how to calculate the APC, you may remember that there were revenue codes for the services that were entered into 3M. And so here you can see things like room and board charges. I mean, there's a whole list, but that's just an example. So it's generally accommodation, which is, the bed, and or ancillary charges. Immediately next to 42, we have 43, which is the narrative description for each revenue code. 44. So 44 has three possible uses. Number one, for outpatient claims, we're going to enter in the HCPCS code, and HCPCS would mean CPT or the HCPCS Level 2 code that describes the outpatient service. And then you can also put modifiers there. For inpatient codes or inpatient cases, we list the accommodation rate, right? So how much is it for the room per day? And then for skilled nursing facility claims, we enter in the HIPS rate. HIPS is Health Insurance Prospective Payment System. And we partner that with a 2-digit assessment indicator to identify the type of assessment. And this is for skilled nursing. 45, this is where we're going to put the from and through dates for an outpatient claim. So the other thing I want to make sure that you are seeing, this claim form is used for inpatient and it's also used for outpatient hospital services, as well as skilled nursing facility. Physician services don't use this form. All right. Form locator 46. This is where we list the units, and units could be like days, number of days the patient was admitted to the hospital. Units could be if the patient is getting blood transfusion, that could also be where units would go. All right, 47. This is where we list the total charges. And so, you enter the revenue codes on each line for 42. And then on each line, you're going to have the dollar amounts. And eventually, it'll all be added up. 48, this is for non-covered services such as copayment. Or if the patient has a plan where they only get a certain amount of inpatient days, this could be the dollar amount after active care has ended. 49 is not used. 50. And 50, I want you to notice, has an A, B, and C. And this is because the patient could have more than one insurance company. They could have a primary insurance, a secondary insurance, and then a third insurance, which is known as a tertiary insurance. All right, so A is for the primary payer, B secondary, and C is for the tertiary. And the tertiary means the third. All right, so then in 51, A through C, every plan that they have, we would list the corresponding insurance ID number. So when a patient registers, you know how we ask them for their insurance cards, it's put into the system, and this is how it makes it over to the claim. 52A through C. So 52A through C is the release of information certification indicator. And this is needed to allow us to release data to other organizations, i.e., the insurance company, so that they can adjudicate, process is another word for adjudicate. So, adjudicate, process the claim. And so, I don't know if you guys ever think about this, but when you go to a healthcare facility, a lot of times they will ask you, they'll tell you, sign here, sign here, sign here, right? And you think you're just signing, and then they normally say, sign here for treatment. But really, it's sign here, you agree for treatment. Sign here, you agree that we can release your medical records. Sign here, you agree that you're responsible for this bill if the insurance company doesn't pay for it. But nonetheless, 52 is for release of information. 53A through C, this is where you're saying, yes, I want the check to go to the provider of the service and not to me. 54A through C, this is if we collected payments from the patient. And it can be a payment for like if they get the blood, if they're getting blood, their insurance could be a require a deductible for blood. Inpatient stays, they could have it, deductible. Um, when you go to the emergency room, sometimes you have to pay a co-insurance. You can put that in there as well. All right, 55A through C. This is the estimated amount due. And I think I mentioned this, but let me just reiterate. Not all insurance companies require information in each form locator, so it's going to be based on what the insurance company requires. All right. 56. This is where we enter in the billing provider's national provider identifier, also known as the NPI number. 57A through C. This is where we enter in other billing provider numbers. So if there was more than one provider. 58A through C. This is where we list the insured's last, first, and middle initial as verified on the insurance card. Perfect example. I am an entrepreneur, so I personally don't have insurance. My husband has insurance through his job, and so I am covered on his insurance. So he would be the insured. All right, 59A through C. This is the patient's relationship to the insured. So for me, I would be spouse. 60. This is the insured's unique identification number. This is the number that corresponds to the insurance company the patient has. So we talked about 50A through C, where we had those different payers. That would be placed there. 61A through C, this is where we would list the group number if it applies. And all of this is on the insurance card. And the way that it works, when the patient access specialist utilizes the system to register the patient, when it's time to generate the claim form electronically, the claim form is pulling from information that was brought forward during the hospital stay or encounter. All right, 63A through C. This is the treatment authorization code or the referral number that is assigned by the payer. This basically, lets them know, hey, we called you to get prior approval. We didn't just do this on our own. And that's if it applies. 64, A through C. This is the control number assigned to the original bill. So we don't use this if this is the original bill. So basically, if we're sending in a corrected claim, we want to put in the claim number for the previous claim so that they can connect the two. And this is only if the payer requires it. All right, 65A through C. This is the employer that provides the health insurance coverage. If this is a workers' compensation claim, like the person got hurt at work, their name could go there, workers' compensation. All right, 66. We are getting close to 81. So 66 is the ICD version number. And this is the indicator that designates what version was used. So we're using ICD-10, and so a 0 is used. But before we convert it over to ICD-10, or when we were kind of in transition from one period to the next, we would use a 9 for ICD-9. And whenever we convert over to 11, I don't know what we're going to use, in case you were wondering. All right, 67. So the first thing that I want you to notice about 67 is that it's not shaded, but what is shaded is A through Q. And then I want you to notice 67 and then A through Q has a little slither of a gray area, and I'll tell you what that is in a minute. So first off, in 67, that is where we're going to list the principal diagnoses, or the first listed if it's an outpatient claim. So inpatient, principal diagnoses, outpatient, first listed diagnoses. And then in A through Q, that's where we would list the secondary diagnosis. You know, the diagnoses that coexist at the time of admission or develop subsequently, that have an impact on the stay. Or if it's outpatient, they coexisted in addition to the first listed. So back to the little slither of the gray portion. That is where you list the present on admission indicator if it is an inpatient claim. So one of the things that I'm hoping that you see is all the things, coming together, if you will, from one week to the next. All right, so 67. The first form locator is the principal diagnoses. And then 67A through Q, those are for our secondary diagnoses. 68 is unlabeled. 69 is the admitting diagnoses. This is required for an inpatient claim. Let me reiterate that for calculating the MSDRG, we do not need the admitting diagnoses, or the admitting diagnosis, I should say, is not used to factor in to what the DRG is going to be, but it is required for the claim form. So that's why when you saw us do the demonstration on 3M, that I always had to put in the admitting diagnoses. All right, and so this is only for inpatient. All right, 70, A through C. This is the reason for the visit if the patient received care for an unscheduled outpatient visit. So unscheduled would be like the emergency department because you don't schedule to be there. 71, the PPS code. So the PPS code would be the MSDRG or the APC, or for other settings that use this claim form, it would be those respective PPS codes. All right, 72. 72 is for external cause of injury codes and the respective POA indicators. I want to remind you that it's in your best interest to go and look at the list of POA exempt codes that are on the CMS website so that you know what is and is not exempt. All right. 73 is unlabeled. 74, A through E. So first thing I want you to notice, 74 is listed first, and then A through E follows. 74, without the A through E, is the place for you to list the principal procedure. This is an ICD-10 PCS code. If this is an outpatient code claim, the it's left blank because you don't use PCS for outpatient. Okay. And then the A through E, that's where you list any secondary procedures. Again, ICD-10 PCS only in 74A, B, C, D, and E. 75, unlabeled. 76 is the attending provider name and NPI. 77 is the operating provider name and NPI. 78, other provider names and identifiers. So this would be like if there's a referring provider, other operating providers. So if there's a secondary or a third assistant surgeon, those names would go there. 80, we're getting close, is where we can list remarks. So an example could be like, hey, Medicare is not a primary payer. And that's because maybe the patient is covered by workers' compensation or an automobile accident. 81. 81 is called code field. And this is basically a place where you can list additional codes if you run out in other areas. Now, this is what they call a situational data element, and this is if it is required by the payer. All right, so we have made it through all of the blocks for the UB04 claim form. And so what we are going to do is take another short break, and we will get into some questions for domain number 4, and then we will wrap up our domain number 4 journey, which will then let us go into domain 5. And then don't forget, I'm going to do domain 2 and 3 last because I want to make sure that I'm able to capture some specific information. All right. All right, we are back and we are going to be focusing on the different tasks for domain number 4, which is regulatory compliance. There are a total of 6 tasks that you should be able to perform. I again want to just reiterate these 6 tasks represent the floor of what you need to know and not the ceiling. As you see different topics, it's so important that you do a personal analysis of what you know and don't know. All right, so we're going to start with ensure completeness and accuracy of health records. And this will be basically where we will have questions, and there won't be any multiple choice questions because I want to see if you know the answers. But before we do that, I wanted to share with you a resource that is available to all AHIMA members. You all, excuse me, my throat is dry. You all should be members of AHIMA before you take this exam. And this article is called The Importance of High Quality Clinical Documentation Across the Healthcare Continuum. And so this is a file that you want to make sure that you review. All right, so let's get into our first question. And the first question is, the Medical Record Committee is assessing various strategies to improve documentation in the medical record, and concerns have been raised that current documentation practices may be insufficient to support diagnoses or to reflect the progress and clinical findings in patient care. So, what do we do in this particular situation? What would be the first step? So, one of the things that I think is important that you all um, know or do is you should be able to answer the question before the multiple choice appears on your exam. How do you do that? Understand the question. So, Medical Record Committee is looking at strategies to improve documentation in the health record. So that's the first thing. Concerns have been raised about what? Insufficient documentation to support the diagnoses, right? So, what would be the first thing that you would do? Well, the first thing that you would need to do is to determine what type of documentation are we talking about? How much is it, right? What specialty? Because you want to know exactly who your audience is for the next steps, because it may not be all providers, right? So you need to look at who is involved in this situation. All right, number 2, according to Medicare requirements, what are the specific timing requirements for completing a patient's history and physical exam, and how do these requirements support safe and compliant patient care in surgical settings? So first off, the H&P must be completed no more than 30 days before or within 24 hours of a hospital admission or registration, but always have to happen before surgery. Now, if you miss the surgery part in the scenario, then that tells you that you need to make sure that you are analyzing the scenario so that you understand what. And so let me just kind of reiterate how this will work again. You're taking the exam and you're reading the scenario. So the first part it says Medicare requirements. Okay, Medicare is requiring something. What is the something that they're talking about? Timing for completing the H&P, right? And how do these requirements support safe and compliant patient care in surgery settings? So pull out the key aspects of the scenario. So we already know more than 30 days before or within 24 hours before a hospital admission or registration, but always before surgery. And how do these support safe and compliant care? Well, this ensures that the providers have up to date clinical information for safe decision making, right? In addition to compliance with regulatory standards. Now, you probably are wondering, well, what's the deal with this 30 days? Well, the provider could have seen the patient 2 weeks ago, right? And so they have that H&P. They, review it just to make sure nothing has changed, and then they can move on with the surgery. All right, let's go on to the next question. To ensure quality of data in the EHR, the copy and paste function should be limited, right? Um, Today, a lot of EHRs that functionality can be turned off. But one of the things that we want to do as a measure is the system correctly identifying that the information is copied from another source so that it doesn't appear that the one person um, documented all of this information today, right? It could have been their own documentation from a week ago, but we always need to know where it came from, okay? All right, next question. In the context of AHIMA standards for high quality health information, what is another term used to describe data accuracy and why is it critical? So, first up, something you should know AHIMA has what is known as a data quality model. And I believe there are 10 items on this data quality model. And it's things like data accuracy, data concurrency. I can't remember all of them right, off the top of my head at this moment, but it's the data quality model. So, anyway, data accuracy is also referred to as data validity. It's critical because it ensures that the data correctly reflects the patient's actual diagnoses, their actual treatments, right? Their actual outcomes. All of this supports safe patient care. All right. Next up, and the last question for this task. Implementing a standardized drop down menu for capturing gender, such as male or female or unknown, is an example of promoting which AHIMA data quality characteristic. And so this would be precision. And why precision? Because when you limit the number of options that are in a drop down menu, you know that you're only going to get those options. No one can add in their own options. All right, we are moving on to task number 2, which is to understand payer specific guidelines. And the one thing that I have to say I struggle with in terms of doing reviews is what payer are they talking about other than Medicare? Because that's something that we all have access to, right? I can't see them having questions that pertain to Blue Cross Blue Shield because everybody doesn't have access to all the Blue Cross Blue Shield documents. Okay. All right. So, a document that acknowledges patient responsibility for payment if Medicare denies the claim. And this is one that I know that you all know because I believe most of you are doing outpatient coding currently, preparing to become an inpatient coder. But this document is known as an advance beneficiary notice or an ABN. Now, if you are, I think one of you does not do coding currently, and you may have forgotten from your initial training um, what an ABN is. Well, Medicare, CMS, actually has a whole website dedicated to ABN or Advanced Beneficiary Notice. All right. Okay. 1 second, because somehow I made my screen extra big. All right. There we go. A 4-digit code that, oh, this is good. This is good. A 4-digit code that describes a classification of a product or service provided to a patient. Funny thing is, when I went over the UBO4 claim form, I just talked about this, and this is a revenue code. All right, next up. Commercial insurance plans usually, and I don't think you're going to have questions like this on the exam where it's a fill in the blank, right? Because it's all multiple choice. But again, I want you to be able to answer the question without multiple choices. Commercial insurance plans usually reimburse healthcare providers under some type of blank payment system, whereas the federal Medicare program uses some type of blank payment system. So you already know Medicare uses a prospective payment system, so that can help you get the second one. And so then that means commercial payers use retrospective, meaning we don't know how much we're going to get paid for the most part until after we get paid. Whereas Medicare, we know how much we're going to get paid. And again, let me just reiterate, nobody has the questions for the CCS exam. And so we're going based on the types of things we think they're going to ask. All right. When a third party payer returns a claim due to missing, inaccurate, or invalid information, what is this called? And so I think one of the things I'll just call out is there's always this conversation on what's the difference between a rejection, a claim rejection, and a claim denial. So let me just review those real quick. So a claim rejection occurs before the claim is processed and is oftentimes due to incorrect data. A claim denial means that the claim has been processed by the payer and they found it to be unpayable. You may recall, what were we doing? Oh, we were doing APCs and we talked about a line item rejection, right? And that was a particular situation where we had entered in a service that is only inpatient, and we were trying to do the outpatient claim. So the edits knows like, hey, this is wrong. So in this particular question, incorrect data, invalid, missing, this is a claim rejection. All right. Last question for this particular area. Healthcare plans that use blank reimbursement methods issue lump sum payments to providers to compensate them for all healthcare services delivered to a patient over a specific period of time for a particular reason. So this is called an episode of care. And we haven't talked about this in this setting, but this would be something that you would have learned about in your coding program if you had a reimbursement course. And so there are all different types of how do I want to call them? Healthcare reimbursement models. We've been talking a lot about we've been talking a lot about the prospective payment system. You learned about retrospective a few minutes ago. There is something that's new and evolving, not too new, but value-based care. We have fee for service. I call that the OG because that's the one, from the very beginning. Oh my gosh, but there are so many other types of reimbursement models. Um, if you Google healthcare reimbursement models, look for the American Hospital Association, the AHA. They have a really cool article that talks about current and emerging payment models. And so on there, you'll see things like Medicare. You'll see all kinds of things. But it's just good to know about it and not know about it. All right. So that was task number 2, I believe. And now we're going on to task 3. Identify PSIs and hospital acquired conditions. So we recently went over present on admission indicators, and we talked about how it's related to the hospital acquired condition. So here we are again. So this is a Medicare website that I would encourage you to go to that talks about hospital acquired condition reduction program. And when I said a few minutes ago that value based was new, it's newer, but it's not new. So the hospital acquired condition reduction program is one of Medicare's value based purchasing program. And really what's happening, Medicare is wanting to pay for value, patients getting better as opposed to patients getting sicker. And so what it is, Medicare is like, hey, how can we reduce these hospital acquired conditions, right? And they do that currently by penalizing us when we have those conditions that are not present on admission because they don't pay for them. And this is the thought process. We didn't cause the problem, or we caused the problem, hospital caused the problem, we should pay to treat the problem. Okay. So this is a Medicare website. Highly recommend you go check it out. Another website that I would highly recommend you check out is the AHRQ. And let me think if I can remember what they are. The Agency for Healthcare Research Quality, I think that's the name of it. But anyway, on their website, they have some really cool information regarding patient safety indicators. This is a topic that you are expected to know about for the CCS exam. So I definitely would take a look. All right, and into some questions. So the first question is, what is the purpose of Medicare's hospital acquired conditions list? And name at least 3 conditions that are on the list. So again, it's not a multiple choice situation because every topic that's on this CCS exam, you should be able to name 3 to 5 things about it. That's when you know it for all topics. So the list is all about patient safety. And it's about patient safety by basically not paying us for conditions that could have been reasonably prevented, right? And so some things are like falls and traumas. So you know how somebody's in the bed, they have the rails up. We tell them, hey, don't go to the bathroom until we come and help you, right? Um, but let's say somebody came in to see the patient. They took the rails down. They then put the rails back up, and the patient's like, "Oh, I am going to go to the bathroom." I had ankle surgery last year, and I was in a room where they got some type of sensor that notices if you start to move out of the bed. And I know you're probably thinking, is it a camera? No, it wasn't a camera, but it was some type of sensor, which I think is really cool because that can give us a heads up that, hey, this patient not supposed to get out the bed and they're on their way out. Other conditions, catheter associated urinary tract infections. So, typically speaking, the patient's catheter should be changed, I think it's every 72 hours. And so, if this patient gets a urinary tract infection that's due to catheter, we could have prevented that. Okay. Another example, stage 3 or 4 pressure ulcers. So, when a patient is admitted to the hospital, the doctor generally writes an order, turn the patient every 4 hours, etc. If we don't turn the patient at all, they get a stage 3 or 4 pressure ulcer, wasn't present on admission. We caused it because we didn't turn the patient. And so now we have to pay for the treatment for that condition. All right, next question. Excuse me. Hospital acquired conditions and POA indicators were implemented to impact which payment system? So, when we talk about payment systems on this exam, you need to know that inpatient is the inpatient prospective payment system, outpatient is the outpatient prospective payment system. The inpatient prospective payment system results in the MSDRG. The outpatient prospective payment system results in the APC. Whoa, what are we talking about here? Present on admission, inpatient. So it would be the inpatient prospective payment system. Knowing the information really helps you navigate a multiple choice question. All right. Patient safety indicators were initiated to capture the adverse effects related to surgery, procedures, and childbirth. And you're probably thinking, well, how would I know that answer? This is another reason why, the websites that I've been showing you, every topic that you see that you don't know the answer, that just means that you just gotta do some additional research so that you are able to answer questions when they're presented to you. Okay. All right. Next up, and we're almost done. We're almost done. Next question. Does a condition that falls on Medicare's hospital acquired condition list count as a complication or comorbidity for reimbursement purposes? So, break down this thing. Talking about Medicare, we're talking about the list. It's on the list. Do we get paid for it? And the answer is no, if it wasn't POA. Okay. But if it was POA, we do get we do get paid for it. So it's all about if it wasn't there before they're admitted to the hospital. All right. Next up, and this is the last question for this task. CMS identified hacks. We call them hacks. Some of these hacks include foreign objects retained after surgery, blood incompatibility, catheter associated urinary tract infection. The importance of the hack provision is that the hospital will not receive payment for these conditions when they are not POA. So this basically is another way to look at the last question that we saw, okay? Because if it's not POA, we're not getting paid for it if it's on that HAC list, on the hack list. All righty, we are going to go on to the next task, which focuses on HIPAA guidelines. All right, so first things first, the Health and Human Services website has a HIPAA for Professionals page. On this page, you need to review the privacy and the security rules. When we get to domain number 5, we're going to be talking about the High Tech Act, and High Tech strengthen breach notification. So definitely recommend you go to this page. All right, let's look at some questions. What is the minimum necessary standard under the HIPAA privacy rule, and how does it apply to the use and disclosure of PHI? So, minimum necessary requires the covered entity to make reasonable efforts to limit the use and disclosure of the PHI to minimum necessary. I like to say it's for treatment, payment, and operations. And I shouldn't say I like to say, but that's in the rules. Treatment, payment, and operations. All right, next question. What are the 3 types of safeguards mandated by the HIPAA security rule to protect electronic patient health information? And the 3 safeguards are administrative, physical, and technical. Administrative is where we have our policies and procedures that clearly show how we will comply with HIPAA. Physical is where we control access by protecting inappropriate access to the data. And then technical is technology and related policies that protect and control the access to it. Next question, under HIPAA, what rights do individuals have regarding access to their information? Well, we have a right to access and obtain a copy of the PHI. And that doesn't mean that they can't charge us for it, but we have a right to get a copy, right? And we also have a right to know who else got a copy of our medical record. And covered entities have to provide that to us within 30 days. Now, if they are experiencing a delay for some reason or another, they need to notify us in writing to remain in compliance. All right, next. What is the purpose of a BAA, or business associate agreement, under HIPAA, and when is it required? So this is a written contract between a covered entity and a business associate. So a business associate is someone that's handling PHI on behalf of a covered entity. So an example could be a third-party billing company. It could be a release of information company. But it's this written agreement that outlines the responsibilities of that business associate related to safeguarding PHI. All right, and this is our last one. What are the breach notification requirements under HIPAA when unsecured PHI is compromised? So that website for HIPAA for professionals, the first item was privacy, security, and then the breach notification. So again, this is an opportunity for you to see as a person, like, okay, what items don't you know? So, covered entities must notify affected individuals without unreasonable delay and no later than 60 days after discovering the breach. If the breach affects more than 500 individuals, they must also notify the Health and Human Services Secretary, and in some cases, they have to notify the media. All right, almost done here. Next to last task. Ensure adherence to AHIMA standards of ethical coding. So first things first, you need to get a copy of the AHIMA standards of ethical coding, and you need to read it. Now, I'm not sure if this is another item that is for members only, but again, you all should be members as you are planning to take the exam. And the first question, why is it important for coding professionals to assign and report only codes that are supported by health record documentation? Compliance, 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 right? Ensuring coding accuracy, compliance with regulations, and we want to prevent misrepresenting the patient's clinical condition or the work that we did, right? So it's only what's documented in the health record. Next question. Describe a scenario in which a coding professional should initiate a provider query. And that's when the medical record is conflicting, incomplete, illegible, ambiguous, and clarification is necessary to assign accurate codes. So, as a reminder, we will be, after we finish domain 5, then we will go to domain 2 and 3. And our time is together is winding down. All right. So, next question. What ethical action should a coding professional take if they become aware of inappropriate coding practices within their organization? So, they should report the issue to management, use the organization's compliance hotline, or take action through the appropriate channels, right? Most places have that hotline. So, you just give that hotline a jingle and go from there. All right, next question. What role does continuing education play in upholding ethical standards of coding? You shouldn't be coding if you don't stay up to date with the current changes. Not only in regards to the day-to-day work, but anything that impacts our work. And the last question, how should coding professionals maintain confidentiality when working remotely? You know, you got to do those safeguards, right? You have to ensure that PHI is secure. You're only accessing what is necessary, and your family and them should not be looking at the records. All right, and we are almost done. We are at last task. Ensure compliance with the Uniform Hospital Discharge Data Set. And here's the first question. What is the primary purpose of the data set? Bottom line is we want to ensure that all hospitals are collecting the same information. So the primary purpose is to standardize the collection of the data elements for all hospital discharges. So earlier I talked about the UB04 claim form. Everybody's using the same data elements, same form, same stuff they're collecting at registration. So consistency, consistency, consistency. This is how they can compare one hospital to the next. You know this answer. What criteria does UHDDS use to identify the principal diagnoses after study? Condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital. All right, next question. Why is UHDDS necessary for coding and reimbursement? It is necessary because it's used for billing, it's used for quality monitoring, statistical analysis, and we have to have consistent and accurate data. That's the name of the game. Okay. All right. Next question. Name at least 3 data elements included in the UHDDS. I have provided you with a list in Blackboard. Make sure you take a look at it. And then the last question. How does UHDDS impact reporting and public health? It provides a standardized data set that facilitates comparison across institutions, but it also supports public health research and statistics. All right, so we have made it to the end of domain number 4.